to no cognitive impairment had better outcomes than those with greater intellectual deficits. And it has been reported by many studies. You can see down there in the slide. Congenital anomalies in the cochlea. A comparison between different inner ear anomalies, incomplete partition type A, incomplete partition type 2, type 1, type 2, common cavity, cochlear hypoplasia, and isolated enlarged vestibular aqueduct with the use of CAP and SEER scores showed that all of these improved significantly after cochlear implantation, and that there was no significant difference between the scores of patients with the different types of anomaly. However, they were never as good as the patients without congenital anomalies of the cochlea. Another issue with this study is actually using the CAP and SEER. It might not be sensitive enough to pick up the differences between those populations. So that could be an issue. Perhaps if a more sensitive test tool was used, they could find significant differences between these groups. And the number of the children included in these groups were not as big, and because these congenital anomalies as well are not that common. The CI outcome in patients with cochlear nerve deficiency is variable as well, ranging from environmental sound perception to conversation without lip reading. In this population, there has been a recent study which found that preoperative ABR and area ratio of vestibulocochlear nerve to facial nerve at the cerebellopontine angle could possibly predict CI outcome in patients with CND. Now, another group of factors are surgical dependent factors. Scalar placement of the cochlear implant electrode. So, deliberate insertion into Scala Vestibuli has been reported to produce comparable results to insertion in Scala tympani. However, unintentional placement in Scala Vestibuli can negatively affect speech perception with CI. So there are issues about the studies, because some of the studies, they tell you and those were mainly looking at when surgeons were trying to insert in Scala tympani and they inserted Scala vestibuli, so there was a negative effect. In a study that we did, we found that in the absence of insertion trauma, scalar placement in Scala tympani versus Scala vestibuli did not affect performance negatively or positively. And another issue is depth of insertion. Deeper insertions were advocated because they widened the range of stimulated frequencies in the cochlea, and they reduced the mismatch between the stimulated frequency and the normal tonotopic organization of the cochlea, or the characteristic frequency in that region in the cochlea. However, deeper insertions were associated with increased possibility of insertion trauma. Poor electrode differentiation at the apical electrodes associated with deeper insertion was also found. And some studies reported possible cross-turn stimulation. Now, however, if you look at all these studies, you will find that in the absence of insertion trauma, increasing the angular depth of insertion of the CI array has a positive impact on CI performance and can improve sound quality as well. The mediolateral position of the electrode array is also a consideration, or what is called the wrapping factor, which provides a metric of how tightly or loosely wrapped an electrode array is relative to the modular wall, was found to be significantly correlated to CNC scores. Longatel, 2014, found significant increase in threshold with electrode to modulus distance. Average slope of 11 dB per millimeter. CNC word scores were significantly correlated with within subject variance of threshold, but not with within subject variance of electrode difference. Soft surgery is a must these days because we want to preserve residual hearing in the implanted ear. And I think we have moved to the concept of, rather than just hearing preservation, into ear preservation. We should try to preserve the structure of the inner ear. And we have to do that, especially if you consider the hearing regeneration studies and the ear regeneration and the cell regeneration studies. And if we damage it too badly, if we damage the ear structures, we are actually damaging the patient's hopes of receiving such management in the future. And if we consider the majority of our pediatric patients are being implanted younger and younger, then we have to really put this in our mind when we are managing them. Essential for systems such as electroacoustic stimulation as well, we must ensure the avoidance of any mechanical trauma and the reduction of any factors that may cause adverse cochlear reactions. Factors dependent on the CI device. So actually, studies have shown there are no significant differences in the performance of the different cochlear implant companies. However, one of the factors, if we consider the cochlear implant device, is having a second cochlear implant. Bilateral implantation has been considered one of the advances that produce significant improvement in performance with cochlear implant. It is argued that the second CI would provide additional benefit, mainly by providing binaural hearing and improved spatial listening. In the real world, this would translate into improved localization skills, better speech perception, especially in noise. Now, children with bilateral cochlear implantation, and I really find this quite important, have faster development of auditory receptive language than children with unilateral cochlear implants. Children with unilateral hearing have difficulty in listening in class, with implications for educational attainment and also for behavior issues. Bilateral implantation is routine from an early age and has become the standard of care in most European countries and the USA. Factors dependent on the CI electrodes or channels. So I'm not talking about the number of electrodes in each system. Despite the different number of electrodes in the CI devices, they provide comparable post-implantation results, which I mentioned before. However, what I'm talking about is that the number of perceptual channels might not actually be equal to the number of active channels you have. So some problematic electrodes may cause distortion to the signal delivered, causing degradation in performance. Positive relationship was found between the number of perceptually distinct channels and speech perception for both adults and children. Now, various studies have demonstrated the relationship between electrode discrimination and speech perception. This is our study. So we found speech perception correlated with electrode differentiation for BKB in quiet and more so for BKB in noise. And in our study, we had 36 adult cochlear implant recipients with acquired deafness, and the inclusion criteria were that they had a minimum of 6-month CI experience, oral mode of communication, and English was their first language because that was the language of testing used. So we did multiple regression models. Stepwise multiple regression analysis were carried out to determine these predictors for BKB in quiet and BKB in noise and CRM, as well as SRT. Factors were added to each model, one at a time, starting with the best predictor. Emphasis was finding the best predictors at each stage, and the model was tested for significance at each stage. If two predictors were highly correlated with each other and with the dependent variable, often only one variable was chosen. So what we entered were the percentage of discriminable electrodes for the full electrode array or at different frequency ranges below 1,000 Hertz, between 1,000 and 2,600 Hertz, and above 2,600 Hertz, the presence of cochlear pathology, AAI, both as categorical continuous variable, duration of deafness, and the etiology of deafness. So the only predictors for BKB in quiet reaching significance were actually the percentage of discriminable electrodes and the presence of cochlear pathology. And the model accounted for approximately 48% of variance in BKB in quiet. Okay. So, okay, BKB in noise. The only predictor reaching significance level was the percentage of discriminable electrodes. The prediction model was statistically significant and accounted for approximately 51% of the variance BKB in noise. And when we looked at the lower frequency, we found that the only predictor reaching significance level was the percentage of discriminable electrodes at the lower frequency range, and it accounted for approximately 42% of variance. So, in summary, found positive relationship between the number of perceptually distinct channels and speech perception for both adults and children. The lower frequency range below 2,600, and in particular the first format region, requires a larger number of electrodes that are discriminable to convey the information than is required for the higher frequency regions for good speech perception. So how do these factors translate? During the pre-implantation evaluation, candidacy may be affected by prediction of prognosis with CI, or it may guide counseling of potential candidates to have realistic expectations and could assist the clinical team when choosing which ear to implant. So expectations is one of the very important factors that we have to address. There are some cases where the expectations is improved life quality rather than speech perception, especially with the children with multiple handicap, for instance. But it would make a great difference for them in terms of life quality. They would be part of the society and even for their families as well. In the post-implantation management process, if factors affecting performance are identified, it can help clinicians derive performance expectations and intervene with rehabilitation of fitting modifications when outcomes do not reach the expected level. So thank you for listening. And if you have any questions, please, we are ready to listen. Thank you.
Thank you very much, Dr. Shaza, for the excellent presentation as usual and the great information. I just want to ask one question because it's clinically relevant and causes sometimes some sort of confusion. So the scenario is some children born with moderate to severe degree of sensory neural hearing loss. They do use hearing aids and their hearing threshold progress and hearing loss progress over time until, for example, at the age of 12 or 13 years, they become severe to profound sensory neural hearing loss. So I want you to highlight those cases, how you consider it as some sort of auditory deprivation, or if the regular use of hearing aid with the progression, they still good candidates for cochlear implantation or no? Because I think this is one point of a common scenario which causes some confusion. Thank you.
So when we're talking about, thank you for your question, and when we're talking about age at implantation, so for the congenitally deaf with severe to profound hearing loss, it's a totally different issue than those who have a progressive type of hearing loss. So when we're saying date of deafness, I mean the date where they became the severe to profound hearing loss with minimum the benefit of hearing aids. So in this scenario where you said, let's say the child only was benefiting from the hearing aids until the age of 12, then that child is actually a very good candidate for cochlear implantation, and we should not delay that child. The reason is that the language areas that were developed during the critical period were actually auditory areas. So the child receptive language is auditory, and if we deprive the child from cochlear implantation or even delay the cochlear implantation, we are at risk of losing this child's auditory areas because of cross-modal plasticity. These areas in the brain that were used for auditory processing, if the child does not receive the cochlear implant as in a timely manner, well, let's say he became 12 and we wait, then if during this waiting period, these areas could be recruited for visual processing because of cross-modal plasticity. In addition to that, if the child is dependent on oral mode of communication, they will be affected severely in terms of communication with society, in terms of schooling, in terms of even social interaction. I've had a child who lost her hearing at the age of 13, and I remember her language actually deteriorated in front of my eyes because the parents refused to get the cochlear implant. And she became shy, she had poor eye contact. After the cochlear implantation, it was like a different child was in front of me. She had excellent eye contact, she was talking confidently, and she was doing well in school. She regained her language and speech. So actually for your scenario, we should go for cochlear implantation as soon as possible, as long as we are sure we fitted that child with optimum hearing aids that were optimally fitted, and yet speech perception did not reach the level that we hope for before we go for cochlear implantation. Each center, obviously, in country will have different levels, but we have to make sure that we gave them the optimum fitting of hearing aids and then gave them the management in a timely manner as soon as we can, if they really need the cochlear implant. I hope that answers the question.
Yeah, sure. Thank you.
We have another question, if you don't mind.
Mm-hmm.
Any experience with CI with deficiency in multimodality in hearing and vision?
Yes. So for me, okay, let's say we have Usher's syndrome. Now with Usher's syndrome, you can expect some of them actually go blind in a quite young age, some of them later age. If even, let's say you are in a country or in a hospital where you usually implant one ear, if you have such a child, give them the benefit of binaural hearing. Give them 2 implants. In the UK, they only provide adults with unilateral cochlear implant, but when you have a deaf and blind adult, there is an exception where they provide the 2nd implant. The reason is as you have seen, there are some benefits in terms of localization, and this is very important for safety issues for the blind. Let's say if they want to cross the street. Another issue is language development. As Garcia et al. Study showed that there was a significant difference between unilateral and bilateral. And with these children, you really have to give them the best that you can in order for them to overcome 2 problems, not 1. But we will need a team that knows how to do rehabilitation for them. And if you implant them at a young age, what we found in our center, you will get better results and the child will adapt to the cochlear implant faster.
Okay.
I don't know if that answers it.
Yeah, I think so, yeah. Do you have a protocol for them, or it's case by case? I assume it's case by case, right?
It's case by case. And I know it's somewhat, some people consider it an ethical dilemma. Let's say the center doesn't have the staff that could deal with these children. And some people think it's unethical to implant them and not provide the proper rehabilitation. But for me, I would go for bilateral implantation at a younger age to give them the best benefit there is.
I have one last question. And I combined my personal question with a question from the audience. If you're implanting around the age of 1 year, more or less, correct? If you decide to implant earlier, talking around 9 months, would you still give a hearing aid trial or no?
Actually, okay, so if you look at the timeline for a neonatal hearing screening, it's 1, 3, 6.
Correct.
So for the majority of our children, we do the diagnosis before the age of 3 months. And we actually provide them the hearing aids as soon as we diagnose them. So even if we do give them a trial, a hearing aid trial, by the time they're 6 months or even 8 months, they've had, some of them had already 6 months. I mean, by the 8 month, 6 month of hearing aid trial. Although we could shorten it for some of the cases, and I do remember some of the cases where we had strong family history, and there it was left corner aided and non-aided audiogram with the same family history in all the older siblings. We actually knew, it's like as soon as the patient became 6 months of age, we could do some sort of aided evaluation with VRA. And at that time, we speeded the process because we had the strong family history as well, where we know they don't receive benefit from the hearing aids. And we just decided for the surgery.
Okay, I just want to thank you for giving us your time today, and it's a very interesting lecture. It's a dear topic to my heart. Thank you again, and thank you for all the participants who were with us today. Any last words, Dr. Shaza?
No, thank you very much. It's been my honor and pleasure to be here with you.
Have a nice
and everyone, thank you for joining us and listening, and have a lovely evening. Stay home and stay safe.
Thank you.
Thank you very much. Thank you very much, Dr. Shaza. Really a sober lecture as usual. It's not new for you. Really, we appreciate your participation.
Thank you, everyone. Have a nice evening. Thank you. Bye-bye.
Bye-bye.